24-year-old man presented to me with a CT scan which suggested right PUJ obstruction. He was asymptomatic. We advised him a DTPA renogram and that confirmed the diagnosis. So we counseled him about the possible option, that is laparoscopic pyeloplasty, and if needed, conversion to open surgery. So the surgery started with retrograde pyelography. Here you can appreciate the jet sign which is marked here, and you can also appreciate a kink in the upper ureter just exactly close to the PUJ. So this is the lateral border of the rectus. This is the subcostal margin, that is the iliac crest. So we make our first approach to the abdomen with the varus at the right iliac fossa. After establishment of the pneumoperitoneum, we make the first port, right hand port, at the subcostal region in the mid-clavicular line. We make the left hand port followed by the optical port. Since it is a right-sided pyeloplasty, so the lever needs to be retracted. We can appreciate the colon. There is the kidney. There's a gallbladder with the liver. We make another port, the objective of which is to retract the liver. There's the gallbladder with the liver retracted, and we catch hold of the apparatus to keep the instrument in position. So we begin with the mobilization of the colon. That's the colon, and that's the kidney. So we incise the peritoneal covering. So this is the first incision over the peritoneum done with the harmonic scalpel. The very objective is mobilization of the colon and followed by the mobilization of the duodenum medially, so that we can identify the ureter and trace it up to the level of the PUJ. I'm using harmonic of Messick, and the camera system that you can see is a Richard Wolf 4K camera system. You can appreciate the in-depth details of the intra-abdominal structures. Beautiful vision. So we are continuing caudally, and we are incising the peritoneum using harmonic scalpel, also doing some blunt dissection and sweeping the colon medially. These are few attachments of the colon to the anterior abdominal wall. This is the right plane, the plane between the peritoneum, and the geroda fascia. These are the few strands. You can appreciate a small hole like area. That is actually a wrong plane where I initially entered into or beyond the geroda fascia. So I quickly realized it, and I proceeded with dissection elsewhere. So say this is the right plane. This is the right plane. Slowly, steadily, we are mobilizing the colon. This is the first and a very important step of any renal, laparoscopic, or open surgery if you are going intraperitoneally. If you are in the proper plane, the dissection becomes easier. So we are sweeping the colon medially further, and we are going now towards the hilum and towards the upper pole of the kidney in order to mobilize the hepatic flexure as well. We won't do an extensive mobilization of the hepatic flexure like we do for partial nephrectomy or adrenalectomy or radical nephrectomies. We'll just do enough for us to do a proper pyeloplasty. This is the incision made over the gerodas, and see, you can appreciate the psoas muscle in the background. That's the gonadal vessel. And that's the IVC. You can also see the gonadal vessel and the IVC for the medially. See, that's the duodenum. Now what I'm mobilizing now is the duodenum. I have gone very close to the duodenum. I realized it and I've stopped there. I'll try to dissect away from the duodenum. See, the duodenum is now swept medially. I'm doing a little bit further dissection of the duodenum medially. You can see this is the renal vein. So one of the rules of pyeloplasty, or something we have been taught always, is you have to dissect up to the lower border of the renal vein for proper exposure while doing pyeloplasty. So I won't go any further cranially. So that's the renal pelvis from the first glance. Not sure. We are continuing the dissection. We'll go layer by layer, and the aim is to dissect and find the ureter first. After I've done that RGP, I have kept one Teremo guide wire in the ureter, supposedly to help me in identifying the ureter. I don't know how much it does, but it has been a practice during open surgery. That's the IVC. So that's the lower pole of the kidney. So that's the ureter. There's a first look of the ureter. That's so. The second step or major step of the surgery is to find the ureter. So we are mobilizing the ureter caudally. That is the PUJ. Now the objective is to dissect the PUJ all around. Also dissect a 2 to 3 centimeter of the renal pelvis, both anteriorly and posteriorly. That will help me in suturing. So these are the facial covering over the renal pelvis. One of them being the Waldeyer sheath. So we can appreciate that there are couple of vessels anterior to the renal pelvis here, supplying the lower pole of the kidney. With further dissection, it will become clear. That's the renal pelvis. I'm catching hold of the pelvis just to strip it off the overlying facial attachments. See, there is the vein. There is one vein there supplying the low pole. So we are using the hook to remove the overlying facial layer, but we will preserve the Waldeyer sheath. So we are catching hold of the renal pelvis, and you can see that we are proceeding with dissection all around. This is of utmost importance while repairing. You can appreciate that I am struggling a bit with the lower pole of the kidney. So it's falling on my PUJ. My left hand is occupied, always occupied, retracting the lower pole. You can appreciate the kink, the one we saw during the RGP. You can appreciate the kink of the upper ureter, just close to the PUJC, or it may be actually the PUJ with a slight kink. So we have made an assistant port for retraction of the kidney. This will free my left hand for further dissection. So there comes the assistant port with instrument, and I will use it to retract the lower pole. That's all. This frees my left hand. You can appreciate an artery and a vein crossing over the pelvis. These are accessories, renal artery and veins supplying the lower pole. Sucker helps a lot when you're planning on doing any blunt dissection. We have asked one of the OT staff to remove the guide wire which we had placed inside the ureter. So you can see the pelvis is being properly delineated now. This is the blunt dissection, and which is best done with sucker. So now we'll dismember the pelvis. So for the dissection of PUJ, before we do that, so the plan here will be to dismember the PUJ, but not completely. I'll keep some attachment of the ureter and the pelvis intact before or till I make or I spatulate the ureter. This helps in prevention of any rotation of the ureter. Helps us to plan the spatulation accordingly. You can see we are dissecting the PUJ all around further. So we begin with the dismemberment. The pelvis opens up. We'll always keep the posterior lip of the renal pelvis slightly longer than the anterior. This helps in suturing. You see, I have dismembered but not completely. Now I will spatulate the ureter laterally till I can appreciate the bulging out of the mucosa. You can see the mucosa bulging out. Longitudinal mucosal foldings. It's beautiful. We'll further spatulate it. It is almost like now 1 centimeter of spatulation or so, 1.5 or so, and we will spatulate it a little bit further. Now we complete the dismemberment. So we'll do the suturing using polygalactin 40. The first suture is taken on the posterior wall outside in, just slight lateral to the apex of the neo PUJ. This bite is on the pelvis. This is the first bite, and the most important one. This will help me align my further bites and will also stabilize my anastomosis. As taught, there is a standard teaching is we should not take a bite at the apex because that may cause a little bit narrowing at the apex, and we don't want that. Suture around the apex has to be interrupted. So I'm outside now. This is the bite taken in the ureter, outside in, and then in the renal pelvis, inside out. Now it is just like we are closing a book. So again, through the ureter, it's a continuous bite that we are taking now as we are proceeding cranially from the apex or proximally from the apex. Bite on the renal pelvis, bite on the ureter. Suturing is always a different ball game. One has to be very good in suturing for pyeloplasties and other reconstructive surgeries laparoscopically. It's with practice that we improve, but it's always has a steep learning curve. So we take another bite at the renal pelvis now and out through the ureter. We'll avoid holding the ureter with our Maryland because we don't want to crush it. So we are catching hold of the suture, which gives the traction and helps us in suturing. The part which I am holding now is the part which will excise. That is the narrow part of the PUJ. Again holding the part of the PUJ which we will resect ultimately. We are almost towards the end of the posterior layer reconstruction. So we are done with the posterior layer. Now the step is to give a DJ stent. What I do is I make another port. It's not a standard practice of mine, but in this case I've made another port just above the PUJ for introduction of the stent. Till this point onwards, I will remove the clamp that I had placed on the catheter. Now I have placed the digestion, the proximal end, in the renal pelvis, and see, we can appreciate the free movement of the digestion, which means that the distal end is in the bladder. Otherwise this free movement wouldn't have been possible. So this is another bite on the other side of the apex. This bite will also be an interrupted one. The important thing is to prevent any kind of bite on the digestion and not to take a bite at the apex. Now we resect the part of the PUJ, we remove it and we send it for histopathological examination. So we have begun closing the anterior layer. There is a bite outside in on the renal pelvis and the bite over the ureter. So we'll take a bite now on the posterior wall. I thought I had completed it, but I thought maybe there's better to take another bite posteriorly. With slight change in direction of the needle, we can do it. Now the plan is to proceed anteriorly, giving continuous bites. You can appreciate the dependent position of the PUJ now. Bite over the renal pelvis. Bite over the ureter. So we are closing the anterior layer now. With continuous suturing. The suture we are using here is 40 polyglactin around body. This is the final bite. So we have taken over the renal pelvis, but more tissue. So we have taken the final bite now over the renal pelvis and through the ureter. We'll close this. So we have finished with the pyeloplasty repair. This is the final repair. So we are now closing the incision we made over the Girotta fascia just as a covering, just to make it retroperitoneal. So it's not mandatory, but it's in our routine practice we do it. So we end the surgery by placing a drain at the right paracolic gutter. The catheter was removed after 48 hours and the drain was removed after 72 hours and the patient was discharged. Thank you so much.